Hi, my name is Katie Connor. I've been working in PA education for about 10 years now. I'm also an orthopedic surgery PA in Charleston, South Carolina. Today, we're going to be talking about my favorite unit, which is our musculoskeletal unit. This is part of a 13-part series to help make didactic year a little bit easier and help you ace your boards. So let's look at the objectives for this unit. This is a big unit, lots of exam and board questions on this one. And this is going to include both our rheumatological disorders and our orthopedic disorders. So let's start out with rheumatology. And the first disease that we're going to cover is fibromyalgia. This is still a little bit of a mystery to us. It's a multifaceted etiology for this disorder, but the key components of the history are going to be chronic, widespread pain for at least 3 months and sleep disturbances. The patients with fibromyalgia spike their cortisol in the middle of the night, and so they're awake and they're ready to go for their day. But that means they're getting unrefreshing sleep, and they're going to have chronic fatigue with this as well. They may also report difficulty with short-term memory. For the physical exam for fibromyalgia, let's look at the picture there. You see these little red dots on the patient. These are predictable points that should cause pain in patients with fibromyalgia. So if you can push on there and reproduce their areas of pain, but they do not have pain at the control sites, so the forehead, the wrist, and the thumbnail, that helps us with this diagnosis. Like I mentioned, this is a multifactorial etiology. They have a hypersensitive pain processing system and a decreased pain threshold. They also have too many pain neurotransmitters, so too much substance P, too much glutamate. They also have a decrease in the amount of pain inhibiting neurotransmitters, so a decrease in serotonin and norepinephrine. They have dysregulation of their dopamine, and they also have a dysfunctional hypothalamic pituitary adrenal axis, which can affect their levels of growth hormone and cortisol. Females are going to be more likely to be affected by this, and here's an important point. This is highly correlated with comorbid depression and anxiety. There's no magic bullet to diagnose this one. It's a diagnosis of exclusion. There are some symptom inventory questionnaires that your patient can fill out, and there's one lab called an antipolymer antibody that will be positive in about 50% of these patients. The first line of treatment for fibromyalgia are going to be your SNRIs, your serotonin norepinephrine reuptake inhibitors, and the three most common ones are going to be Effexor, Cymbalta, and Prestique. Effexor was the first generation, which means that it has more side effects, but it's usually cheaper. Cymbalta is the son of Effexor, and then Prestique is the grandson. So we have kind of those three generations of medications there. There is a newer one on the market, Fetzima and Savella. These are specifically formulated to treat fibromyalgia. We also have antidepressants, our SSRIs and our tricyclic antidepressants, things like fluoxetine, paroxetine, amitriptyline, and nortriptyline that can be effective for these patients. For pain, ranging on the severity, depending on what that is for them, we can start with yoga, Tai Chi, anti-inflammatory medications, tramadol. Our neuropathic medications like pregabalin and gabapentin can also be effective. The sleep disorders, we can treat this with things like Ambien, Sonata, or your benzodiazepines like Xanax or Klonopin, but keep in mind that these can be habit forming, and so we only want them taking these when they're having the sleep disturbances, not just taking them on a regular basis. Muscle relaxants can also be helpful for some of the muscular pain for these patients. So key points about fibromyalgia: chronic widespread pain, sleep disturbances, and your first line therapy for treatment for these are going to be your SNRIs. Next, we're going to talk about gout and pseudogout. These are very commonly tested on your exams, and I want you to learn them together because you can kind of remember that they're opposites. So gout is going to be this acute, intense kind of pain that develops over 12 hours, and it's going to be pain even with light touch. The sheet touched my foot, and it was so painful. In pseudogout, this is going to be more of an insidious, gradual onset of symptoms that can occur usually over days. Both of these have a very similar physical presentation, and they can affect one joint or many joints, but it's going to be a red, hot, swollen, edematous joint, and it can look like infection. With gout, podagra, the big toe, is going to be the most likely place to be affected, whereas the knee will be the most likely affected in pseudogout. If we look at this second picture down here, that's called a tophi. This is an enlarged red area that can drain this thick chalky toothpaste-like substance. So it's not a purulent drainage, but it's a thicker, whiter toothpaste-like substance. Both of these are crystalline arthropathies, meaning that it's crystals that are depositing in the joint and causing irritation in the joint lining. In gout, it's going to be uric acid crystals, and this is highly genetic. They have this because they have high levels of uric acid in their blood, so hyperuricemia. They can either overproduce that uric acid or more commonly, they will underexcrete that. So 90% of gout patients are going to be underexcretors. In CPPD or pseudogout, this is typically idiopathic, but these are going to be calcium pyrophosphate crystals rather than uric acid crystals. Both of these diseases can be flared by triggers, things like high purine foods. So if you read in the question that they've been eating anchovies, sardines, organ meats like kidney and liver, this is a known trigger. High fructose corn syrup, which is common in a lot of sodas, seafood, alcohol, dehydration, and thiazide or loop diuretics because they dehydrate the patient, and that causes precipitation of the crystals into the joint. Males are going to be 3 times more common for gout, whereas pseudogout is kind of equal. Most common onset of symptoms is going to be in the 4th decade, so about 40 years old. If we can get a joint aspiration, we can send that for fluid and crystal analysis, and that will be looked at under a microscope using a polarizing filter. Gout is going to be notated in your question as a negatively birefringent linear type of crystal, whereas pseudogout, remember P for pseudogout, P for positively birefringent. So this is going to be a positively birefringent rhomboid shaped crystal. So linear for gout, rhomboid for CPPD. In gout, the patient may or may not have high levels of uric acid in their blood. On X-ray, we look at this bottom picture here, and we can see something called a rat bite erosion. It looks kind of ratty along the joint line. In CPPD, we see something called chondrocalcinosis, which looks like somebody took a salt shaker and sprinkled all of these little calcium flakes into the joint. Treatment for this is we want to avoid the flare. So a very strict diet where we're avoiding these triggers and making sure that the patient stays well hydrated to avoid that precipitation of the crystal into the joint. If they have an acute flare, the first line treatment for that is going to be anti-inflammatories and prednisone. If this is a patient that has chronic flares and they're an underexcretor, which remember is going to be the most common type, we can treat them with colchicine and probenecid are common ones for treating that. Or overproducers, we can treat with allopurinol and febuxostat. I want to simplify something real quick before we get to the rest of these disorders. I'm going to be mentioning things called Demards and Biologic. Demards stand for disease-modifying anti-rheumatic drugs. And I want to separate these out as far as some of the differences for these. Demards tend to suppress the entire immune system, whereas the biologics are really targeted for a specific immune process. Demards are usually pills, biologics are usually injectables and infusion, but usually is kind of the key word there. That can obviously vary. Demards take a longer onset for effect, whereas biologics are typically 4 to 6 weeks. Demards are cheaper, which means they're better covered by insurance, whereas biologics are typically very expensive. An insurance company usually wants you to fail a couple lines of treatments before they'll pay for those biologics. Because Demards suppress the entire immune system, they have more side effects, and biologics tend to have less side effects because they're specifically targeted for that immune process. Let's start out with polymyalgia rheumatica. This is going to be an acute onset of shoulder and hip pain that causes a lot of stiffness in this patient. So stiffness after periods of rest, stiffness lasting longer than an hour in the morning, difficulty arising from a seated position and turning over in bed. On physical exam, you'll see that this patient has severely limited range of motion in both the shoulder and the hip girdles. They may also have a low-grade fever, distal pitting edema, but they will have normal muscle strength and no muscle atrophy. Those are pertinent negatives. We don't know what causes this. It's an autoimmune and an inflammatory condition. And here's your exam question. It is associated with the HLA-DR4 haplotype, and 15% of these patients will develop temporal arteritis or giant cell arteritis. We covered this in your HEENT unit. This is going to be more common in Caucasian females, and it's going to start on onset right at the age of about 50 and above. For diagnosis for this, we have our non-specific inflammatory markers. The erythrocyte sedimentation rate and the C-reactive protein will be elevated. A pertinent negative is that they will have a negative rheumatoid factor and a negative ANA. If they have symptoms that are consistent for that temporal arteritis, we know that the diagnosis that's definitive for that is going to be a temporal artery biopsy. If you remember when we talked about that in HEENT, we want to treat that with high-dose steroids to prevent the most common complication, which is blindness. So the treatment for Polymyalgiarheumatica is also going to be prednisone, and this should give the patient a pretty rapid response. So key points on this one: shoulder and hip pain, stiffness, highly associated with HLA-DR4 and giant cell arteritis. We want to treat this with prednisone. Next, we have rheumatoid arthritis and juvenile rheumatoid arthritis. Both of these have an insidious or gradual onset of symmetrical polyarteritis, and the symptoms by definition have to last longer than 6 weeks. Some of the key characteristics of the history that can help us separate this from osteoarthritis are pain that's worse in the morning, worse after inactivity. The pain usually lasts longer than an hour, typically until lunchtime, and the pain improves with activity. They may also have systemic symptoms like fatigue, malaise, and a low-grade fever. One of the key history components of juvenile rheumatoid arthritis is going to be spiking fevers once or twice a day at usually the same time. This is called a quotidian fever. On physical exam, it can affect lots of joints, but in order of the most common to least common: MCP, wrist, PIP joints, so the proximal interphalangeal joints, metatarsal phalangeal joints, shoulder, ankle, and cervical spine. It can also less commonly affect the hip, the elbow, and the temporomandibular joint. On exam, these joints are going to be stiff. They're going to have tenderness. They'll have painful or limited range of motion, and they may also have inflammation in the tendons, so tenosynovitis. On RA, as it develops into the more advanced stages, like you can see on this picture here, they can develop boutonniere deformities, swan neck deformities, finger ulnar drift, and then hammer toe in the feet. Juvenile rheumatoid arthritis, a key finding on the physical exam for this one, is a salmon-colored migratory rash that affects the trunk and the extremities. And they may also have psoriatic plaques in the 5% of people with JRA that also have psoriatic arthritis. We don't know what causes rheumatoid arthritis. We know that there's a huge genetic component. 50% of patients will have a family member that is also affected. It can be triggered by infection, smoking, hormones, and vitamin D deficiency. But we know that the pathophysiology of this is that autoimmune complexes settle into the joint, kind of like sand or grit, and they irritate that joint lining, causing synovitis, advanced cartilage destruction, and then eventually a gross deformity of that joint. Not only does this affect the joint, but it can affect the skin, the heart, and the lung, causing effusion or fibrosis, and the eyes. Typically, these patients will have dry eyes or uveitis. In juvenile rheumatoid arthritis, it can be oligoarticular, which is 4 joints, polyarticular, which is 5 or more. They can also have inflammation at the insertion sites for tendons and ligaments in 15% of patients. It can be systemic in 10% of patients. And then those psoriatic arthritis patients, those will be the ones with the psoriatic plaques. Females are going to be more likely to be affected by this. They have a 3 times increased risk. For rheumatoid arthritis, the age of onset is typically 35 to 50. With osteoarthritis, that's going to be an older disease, so 50s and above. So this is an early onset arthritis. In JRA, by definition, it needs to be under the age of 16, but most commonly it appears at ages 1 to 3. On diagnosis for this, we're going to have an elevation in those nonspecific inflammatory markers, the CRP and the SED rate. 70% of patients will have a positive rheumatoid factor. 60% of patients will have a positive anti-nuclear antibody, or an ANA. An anti-CCP is one of the first labs that will be positive in these patients. On joint aspiration, you can look at analysis for gram stain, cell count, and culture to make sure that this is not an infection. On X-ray, things that we can find that are common: cervical spine instability is very common in people with rheumatoid arthritis. And that tells us we need to be careful with hyperextension of the spine, for example, when we're intubating these patients. They may have localized osteopenia or kind of grayish appearing X-rays. joint erosions, narrowing, subluxations, ankylosis where the joint autofuses, and then synovial cysts, which looks like little black dots around the joint. Treatment for this, we want to treat it aggressive and early to avoid this disfigurement that is associated with longstanding RA. Corticosteroids and anti-inflammatories are kind of the first line. Then we have several classes of medications. We start again with those DMARDs that we discussed. We have biologic immunomodulators, biologic tumor necrosis factor inhibitors, and then JAK inhibitors. Those are the third line. On JRA, we have a variety of medications to treat this as well. So kind of going down our algorithm there. Next, we're going to talk about polymyositis and dermatomyositis. This is an idiopathic, unknown, autoimmune inflammatory myopathy, and there's triggers for this. We know that there's both infectious and medications that can be trigger for this. So Kawasaki B, HIV, hepatitis B, and influenza are common infectious triggers. Medications, things like ACE inhibitors, phenytoin, and hydralazine. With this, the patient is going to develop symmetrical proximal muscle weakness that's developing over weeks to months in both the upper and lower extremities. It becomes very difficult for them to kneel, stand, climb, hold their head up. Normal bodily movements become very difficult and painful for them. 30% of patients will also have muscle pain, and 30% will have dysphagia if it affects the esophageal muscles. So in polymyositis, this is just the symmetrical proximal muscle weakness. They will have normal sensation. In dermatomyositis, they will also have skin findings or dermatological manifestations of this. And some of the more common ones that you'll be tested on are soft tissue calcification. So look at that top picture there. You can see these calcifications. Photosensitive rash, the V-neck is the front and the shawl sign is the back. So anywhere that the sun may touch them, they'll get this photosensitive rash. Mechanics hands are hyperkeratotic papules on the pads. Lilac heliotrope rash, it looks like she's wearing kind of a purplish eyeshadow there. Gottrin's papules on the bottom picture here, we can see this reddish purple discoloration on the dorsal finger joints. Raynaud's, where they get a spasm of the blood flow to the fingers and they can get this whitish and red transient discoloration. And then a malar rash, which occurs on the face. This is very rare. I highly doubt you'll have a lot of questions on this one on the boards, but we still should know this one. So it's rare. African-American are 5 times an increased risk for this one. Females are a higher risk, and the onset is about 45 to 60 years old. We'll have an elevation in our inflammatory markers, so the SED rate, the CRP. We'll also have an elevation in creatinine phosphokinase and aldolase, which indicates that there's a muscle breakdown there. 50% of patients will have a positive ANA, and there's a couple antibodies that are also positive for this. So an anti-Jo, an anti-Me, an anti-SRP. On nerve conduction study, they may have decreased nerve transmission because of the inflammatory process in the muscles. And then the definitive criteria for this one is going to be a muscle biopsy that on the cellular level will show inflammatory process, necrosis, and monocyte invasion of that muscle tissue. Treatment for this is going to be pretty similar to our algorithm. So we got prednisone as our first line, DMARDs, and then our biologics. Lupus, very highly tested on your exams. This is another autoimmune inflammatory disorder. We, again, don't know what causes this, but we know there's a genetic correlation, hormonal components, UV exposure, vitamin D deficiency, and then medications can also be a trigger. Things like estrogen, anticonvulsant medications, and antiarrhythmics. Smoking plays a role, and dysfunctional T cells. So there's a lot going on, again, a multifactorial etiology. For the physical exam and the history of this, there's a triad: fever, arthralgia, and rashes in these patients. So we know if it's a triad, we know it's going to be tested. These patients may also have a history of multiple miscarriages because they have a hypercoagulable state due to antiphospholipid antibodies and the lupus anticoagulant. So let's look at all the areas that are affected by lupus. So we have hematologic manifestations. They have a hemolytic anemia. They have antibodies on their red blood cells, thrombocytopenia, leukopenia, and that hypercoagulable state. Arthritis, it affects mostly the MP joints and the PIP joints in the hands, the wrists, and the knees. Mucocutaneous, they get that photosensitive rash, malar rash on the face that you can see there, discoid rashes on their legs, oral ulcers, Raynaud phenomenon, that discoloration in the fingertips, livido reticularis. This is the second picture down here. This is kind of a mottled reddish purple rash on the legs. Alopecia, hair loss. Renal, it can affect the kidneys. It can cause a nephritis. Neuropsychiatric, seizures, psychosis, headaches, mood disorders. Pulmonary, it causes hypertension, pulmonary hypertension, pleuritis, and interstitial lung disease. The gastrointestinal manifestation, nausea, dyspepsia are common. Cardiac manifestations, pericarditis, coronary artery disease, and myocarditis. And then finally, the eyes are affected, retinal vasculitis or chronic dry eye. This is 90% is going to be females of childbearing age. I'm going to say that again because it's important. Females of childbearing age. African Americans have a much higher risk for this, so 2 to 4 times increased risk for this one. On labs, these are important. They'll have an elevation in those non-specific inflammatory markers, so ESR and SED rate and CRP. They're going to have a decrease in complement, so a C3 and C4. 90% of them will have a positive ANA. On CBC, they have a hemolytic anemia. Remember that direct Coombs test that we talked about in your hematology unit? Because they have antibodies to their erythrocytes, they'll have a positive direct Coombs test. The antibodies for this, anti-dsDNA, anti-Smith, anti-Rho, anti-La. Anti-Smith is going to be the most specific antibody for this one. They'll also have an antiphospholipid and an anticardiolipin antibody. If they have nephritis, you can do a renal biopsy, and on your analysis, you may note that they have hematuria and proteinuria. Treatment for this, anti-inflammatories, Demards, and our biologics, again, with that kind of algorithm that we have there. Next, we're going to talk about Sogrin syndrome or Sicca syndrome. There's one word I want you to remember about this one. Dry, 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 dry. Everything's dry in Sicca syndrome. This is an autoimmune inflammation of the exocrine glands that causes severely dry mucous membranes. This can occur by itself, or it can be in association with patients who have lupus, rheumatoid arthritis, and scleroderma. So remember, dry, dry, dry. They're going to have a dry, gritty feeling in their eyes. They're going to have difficulty eating dry food because they're not producing enough saliva. They may get hoarse. They may have cavities because remember, saliva is antibacterial. They may have trouble swallowing. They're going to have dry, itchy, scaly skin, anhidrosis, dyspareunia because they're not producing that vaginal lubricant, nasal dryness, bloody noses, arthralgias and myalgias. Those are non-specific symptoms, but everything is dry, dry, dry. On physical exam, the specific findings are going to be bilateral parotid gland enlargement, this red kind of smooth tongue, angular cheilitis, gingival inflammation, sparse, brittle hair, dilated conjunctival vessels, Raynaud's phenomenon, and then annular erythema with scales on the face and neck. So a lot of dermatologic manifestations on this one. Females are going to be much more common, and the onset is going to be about age 50 to 60. Our non-specific inflammatory markers will be elevated, so SED rate and CRP. 80% will have a positive ANA. 50% will have a positive rheumatoid factor. Anti-Rho, anti-La will also be positive. Here's going to be your exam question. The Schirmer test, which we can see up here, measures tear production. It's going to be decreased, so a decreased tear production. That's a good board question. Measuring the amount of saliva that they produce. Normocytic anemia, not really that important. Leukopenia, not really that important. Salivary gland biopsy is going to be the most definitive on this one. And what we'll see on the rose bangle stain is that they have lymphocytic infiltration. So that's the most definitive test. But the Schirmer test is the most commonly asked on your boards or on your exams. Treatment for this is prednisone is going to be our first line therapy. We can use medications to increase their saliva production. We can use eye lubricants to help with that dry eye feeling, and then treating their arthritis type symptoms with things like hydroxychloroquine. Scleroderma and Crest syndrome. These are very rare disorders. This is an autoimmune deposition of collagen in excess of what it should be in the skin, in the organs. You also have an arterial fibroproliferation of collagen, and then that eventually causes ischemia because it closes down the arteries. History on this one, itchy skin, skin edema followed by sclerosis of the skin, and this affects the fingers and the face first. The skin becomes really tight and very shiny, kind of like somebody's pulling a glove over their skin. Anhydrotic, they don't sweat. They may have hair loss. Morphia is in the top picture there. This is discolored sclerotic skin patches. Salt and pepper pigmentation is the bottom picture here. That's common. Joint contractures as that skin gets tighter and tighter and tighter, and then eventually fingertip ulcers as you develop ischemia in the arteries going into the fingertips. Crest syndrome, C-R-E-S-T, stands for calcinosis of the soft tissue, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias that most commonly occur on the face, the chest, and the hands. We know with this that it has a very big range in the severity of the symptoms. So this can range from cutaneous only all the way into organ involvement. What happens is the fibroblasts start depositing this collagen, and they've been triggered by something. So silica, solvents, and radiation, these are environmental exposures that we know cause these fibroblasts to kind of go nutsy cuckoo and start developing and start depositing the collagen where it should not be. This is kind of an interesting point. There's a population of Choctaw Indians. This is a very specific genetic population. They have a 20 times increased risk for this. So if you ever see Choctaw Indians on the boards, you should be thinking about this one. We're going to have an elevation in our nonspecific markers, our SED rate, positive ANA in 95% of these patients, antibodies, so anti-SCL70, anti-centromere, anti-RNA polymerase. On X-ray, we will also see soft tissue calcinosis and then resorption of the fingertips as they develop ischemia to the area. Those little bony tips will start to kind of melt away. Nail fold capillary microscopy. On this, what you're looking at is you're looking for these dilated kind of tortuous these vessels that are not normal in shape. If you think that this is a severe form, you want to consider imaging of all of the organs that could be involved. Treatment for this, same algorithm, prednisone, Demards. Vasodilators also play an important role here because we want to ensure the patency of those vessels so that we reduce the likelihood that they'll get ischemia into the fingertips. Next, we have polyarteritis nodosa and Kawasaki's disease. Both of these are medium vessel vasculitis and not very common. Both of them are pretty rare. Polyarteritis nodosa affects the population about 45 to 60. And in this, they get necrotizing lesions in the medium vessels. This can cause weight loss, peripheral neuropathy, transient monocular blindness, a lot of skin findings with this one, digital gangrene, livido reticularis, that same rash we talked about with lupus, Raynaud's phenomenon, malleolar ulcerations. When this happens and they get the inflammation in these vessels, they can get aneurysms, hemorrhaging, thrombosis, infarction to the kidneys, the liver, the heart. This one is highly associated with hepatitis B. So polyarteritis nodosa, medium vessel vasculitis, highly correlated with hepatitis B. The most common question you'll be asked about polyarteritis nodosa is going to be on angiography. When you're looking at those vessels, what is it going to look like? It's called the rosary sign, and it looks like little rosary beads that you can see in the affected arteries. If you do a biopsy of those arteries, you'll see that there's something pathologically wrong with them. So neutrophil incorporation of neutrophils, necrotizing changes to that artery. Treatment for that is going to be corticosteroids and cyclophosphamide. In Kawasaki's, this is going to be a younger population, and Asian people have 10 to 20 times risk for this. So this is going to be usually less than 5 years old. They're going to present with a very, very high fever, so 102 to 104 for at least 5 days. 4 of the following. Remember how I said Sogrin's was dry, 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 dry? Kawasaki's is going to be red, 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 red. Everything's red. So bilateral painless conjunctival injection, red eyes. Palmar and plantar erythema, red hands and feet. They may have desquamation of the skin on their digits. Lip fissures and bleeding. If you look at this bottom picture here, very red lips, very red tongue. We call this a strawberry tongue. Oral erythema, red mouth. Diffuse maculopapular rash, and then cervical lymphadenopathy of greater than 1.5 centimeters. We again know this is a medium vessel vasculitis that actually splits the internal and external lamina. And here's your board question on this one. So we know it's a younger patient. Asians are more common, red, 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 red. The most important diagnostic for this is to get serial echocardiograms because they have a 25% risk of a coronary artery aneurysm if this is untreated. So serial echocardiograms are going to be the most important diagnostic imaging for this patient. We may see that we have the nonspecific inflammatory markers, SED rate, CRP. They may also have an elevation in liver enzymes. Treatment for this one is kind of interesting. So we have immunoglobulins and aspirin. Remember, we don't normally give aspirin to kids because it can cause Rye syndrome, but aspirin is actually the first-line treatment for Kawasaki's disease. Next, we're going to talk about our seronegative spondyloarthropathies. These are seronegative, meaning that they have a negative rheumatoid factor, but all of them will have a positive HLA-B27 haplotype. That's a really important point here. So autoinflammatory disorders, positive HLA-B27, negative rheumatoid factors. All of these are treated with anti-inflammatories and Demards. There's 3 diseases we'll talk about here. Ankylosing spondylitis is the first one. This is going to be a younger male, usually at age 30 in onset. He's going to present with progressively worsening lower back pain and decreased range of motion, stiffness with activity, and usually eyes are affected as well, so an iritis. This is a progressive fusion of the vertebra, the hip, and the shoulder articulations with the spine. Here's your exam question on this one. Bamboo spine and vertebral squaring. So it looks like their spine turns into bamboo, where you have these kind of nodules where the joints should be. Vertebral squaring, it should be this kind of biconcave disc, and they kind of form this square, and you can see that in that top picture there. Psoriatic arthritis. Psoriatic arthritis is a combination of psoriasis and arthritis. They usually develop these really diffuse swelling in their fingers. We call this dactylitis. It can also cause nail pitting and nail splitting. On X-ray, here's your exam question. What is the most common X-ray finding on psoriatic arthritis? Is going to be a pencil-in cup. This is a combination of both erosion and bony resorption that resembles a pencil in a cup. Finally, we have reactive arthritis. Used to be called Reiter syndrome, but we don't call it that anymore. This is a triad of conjunctivitis, urethritis, and arthritis. And the way we remember this is can't see, conjunctivitis, can't pee, urethritis, and can't climb a tree. There's our hip and knee arthritis for this one. The most common finding on this one is going to be dactylitis, but you have kind of a variety of things that are associated with this, but probably will not be tested. That's all of our rheumatologic disorders. So we're going to move on to our general musculoskeletal disorders. And we're going to start out with muscular dystrophy. This is an X-linked disorder, so we know it's much more common in males. It's a defect in dystrophin, which is a component of normal muscular fiber. So they have a defective dystrophin. This causes progressive proximal to distal muscle weakness. And so in the history, this patient is not walking by age of 18. They have some kind of family history of this, intellectual impairment, frequent falling, difficulty standing, and then loss of all ambulation starting at about age 7. Here's your board question on this one, the Gower sign. This is where the patient can't stand up on their own because they don't have enough core muscle strength. So they'll start out being prone on their hands and knees and kind of walk up their body into a standing position. So Gower sign for muscular dystrophy. A waddling, wide-based gait because they have weakness in their gluteus maximus and their gluteus medius muscles. If you look at the picture here, calf pseudohypertrophy, they develop fatty infiltrates into the defective muscle tissue. Hyperlordosis, you can see in this picture here, that lumbar curvature of the spine. This develops in response to hip extensor weakness. Toe walking, decreased or absent deep tendon reflexes in the legs, and then finally joint contractures. This is 1 in 3,500 males. Genetic testing is going to be definitive for this. We know it's an X-linked disorder. Delayed milestones on those well child checks. They're not able to sit unassisted by 9 months. They can't walk by 18 months. They have pretty obvious motor, speech, feeding, writing, communication deficits by about 48 months. They have an elevated CPK, creatinine phosphokinase, that tells us that there's something wrong with the muscle tissue. And then a muscle biopsy will be definitive for this as well. Treatment for this is we're trying to prolong and make them have a better quality of life. So surgeries for joint contractures, spinal deformities, we want to fix those for them. Corticosteroids and some biologic medications, some limited biologic medications. Death usually occurs by about age 30 because of respiratory failure from the diaphragm. Osteogenesis imperfecta. For this one, it's an autosomal dominant defect in type 1 collagen. And type 1 collagen is a component of bone tissue, ligamentous tissue, skin, dentin, and sclera. These people will get lots and lots and lots of fractures from minimal trauma. So in the history, multiple birth trauma or multiple birth fractures, fractures from very minor trauma. These patients tend to have a very high tolerance for pain. And so parents get accused of child abuse because they're like, why didn't you bring your kid in? And they have all these fractures. Well, they didn't complain of pain. So a high pain tolerance. Easy bruising. Deafness and hearing loss is common. About 50% of these patients have it because those little tiny bones in the ears, the ossicles, they fracture easily. A lot of physical exam findings on this one. Bluish gray tint to the sclera. You can see that in the top picture there. Triangle shaped face, macrocephaly, barrel chest, pectus carinatum, which is a protrusion of the sternum, scoliosis, bowed limb deformities. We can look at the arm in this bottom picture here or in the leg. Tooth breakage, loss, or discoloration if they have dentinogenesis imperfecta as well. With these patients, it's interesting that they get lots of fractures, but their fractures still heal at a very normal rate. Testing for this, genetic testing is definitive. A skin punch biopsy will look at the collagen and they'll do a synthesis analysis of the collagen. On bone biopsy, you'll see a decreased cortical width, reduced trabecular volume. On X-ray, some findings, and here's some good exam questions. Popcorn bones. These are kind of scalloped radiolucent areas that have radiodense rims, so they look like pieces of popcorn. Enlargement of the skull sinuses, a shepherd's crook femur, transverse long bone fractures, extra bones within those skull sutures. These are called Wormian bones. And then hypercalcemia is present in 30% of these patients. Treatment for this is orthopedic surgeries to correct those deformities. So things like intramedullary femoral rods, spinal fusions, and then bisphosphonates, because we know that these inhibit the osteoclastic function. So remember those end in dronate, so pimindronate and alendronate. So key points on osteogenesis imperfecta for your exam. It's a defect in type 1 collagen, lots of physical exam findings on this one, multiple fractures from minimal trauma, and then treatment is going to be bisphosphonates. Next, we have acute compartment syndrome. This is definitely an orthopedic emergency and one that you want to be able to recognize and treat quickly. With this, you have an increased edema or fluid in these compartments. And so eventually it will compress the arterial flow, which causes ischemia and eventually infarction into those tissues. So there's 6 P's of compartment syndrome. The first one is going to be pain out of proportion. So pain that's unresponsive to high dose of narcotics, pallor, paresthesias, poikilothermia or cold, pulseless and paralysis. All of those are later findings in compartment syndrome. On physical exam, instead of being nice and mushy and bouncy, those compartments are wooden on palpation. In the later findings, decreased 2-point discrimination because that nervous function is being compromised. Pain worsened by passive stretching of the muscles. That's important. We know that there's several compartments in several areas of the body. So the lower leg has 4, the forearm has 4, the wrist has 6, and the hand has 10. The most common cause of acute compartment syndrome is going to be fractures, and tibial fractures specifically. Tight casts or tight splints can cause an acute compartment syndrome because you have this non-expanding, basically restriction of that area. And as that area swells, you have that restriction on there. Anything that causes massive edema, gunshot, stabbing, crush, hemorrhage, any kind of vascular injury that causes massive amounts of bleeding. This is again more common in vascular injuries because of that massive amount of bleeding. Tibial fractures, I mentioned that, and people who are on anticoagulation because they bleed more. So that makes sense. The diagnostic criteria of this is to directly measure the compartment pressures. And this can either be done with an external pressure gauge or a transducer and catheter. They may also have an elevation in creatinine phosphokinase because we know that that's produced when the muscle tissue is breaking down. Treatment for this, you can see in this top picture there, this very large incision. This is called a fasciotomy. You're opening up the compartments to allow for expansion and thereby reducing compression on the vessels and on the nerves. If it's caused by a cast or splint that's too tight, you want to remove that. But this is an emergency. So ischemia begins within 6 hours and it becomes irreversible at 12 hours. So you want to know how to identify this and get orthopedics involved in this patient's care right away. Next, we have soft tissue sarcomas. In soft tissue sarcomas, the patient's going to present with this enlarging, painless, firm mass. Remember that cancer is not painful. The causes of this can range from sporadic genetic mutation, genetic disorders that are more common for this is neurofibromatosis, familial adenomatous polyposis, prior radiation in the area, and then environmental exposures to things like vinyl chloride or arsenic. The benign ones, giant cell tumor, this is usually a joint or a tendon sheath. Glomus tumor affects under the nails. Benign or malignant, this could be a nerve sheath tumor, and then these are all of our malignant ones. Fibrosarcoma is a tumor of connective tissue. Synovial sarcoma is going to be the joint capsule. Rhabdomyosarcoma is going to be skeletal muscle. Liposarcoma is going to be fat. Leiomyosarcoma is going to be smooth muscle. Angiosarcoma is going to be a tumor of the lymph and the blood vessels. Clear cell sarcoma is going to be tendon and aponeuroses. And then Ewing sarcoma is a very malignant tumor of the bone or the soft tissue. Most commonly affects the leg, the pelvis, and the chest wall. In order to better image these, we would order CT, MRI. To get a cellular diagnosis, we would do a tissue biopsy, and that really depends on where it's located. So you could either do a fine needle aspiration, core needle biopsy, an incisional or an excisional biopsy. And then if it's something where you're worried about metastasis, you would want to do a PET scan for staging. Treatment is to take it out, so excise it, and you need to consider whether you need to complete an entire amputation if it affects a limb. Radiation and chemotherapy depending on the staging for this tumor. Next, we have osteoporosis and osteopenia. We also covered this in our endocrine unit. I run a fracture liaison service, so this is kind of near and dear to my heart. Osteoporosis and osteopenia is thinning of the bone that causes the bones to be brittle and more likely to fracture. So in the history, the patient may have a fragility fracture of the hip, the spine, or the wrist from a fall from a standing height. The patient is typically postmenopausal or has had an ovarian removal. Smokers, alcoholics, sedentary, poor diet, chronic steroid use, these are all predictive factors for osteoporosis. The patient typically has a loss of height if they've sustained a compression fracture. They have low BMI, they're usually very thin. They may have a kyphosis or an exaggerated curvature of the spine. This is the loss of bone mass due to a decrease in estrogen. So vitamin D deficiency can cause this. They can't transfer the calcium from the serum to the bone. Calcium depletion from things like smoking or drinking too much alcohol. Hyperparathyroidism can cause an early onset osteoporosis. Conditions that cause decreased osteocyte formation like diabetes or steroids. Malabsorption or hypocalcemia from diet, hypomagnesemia, liver disease, renal disease, GI surgery where they've removed part of the gut, celiac disease, and then chronic proton pump inhibitor use because it turns off the acid production. You need acid in order to absorb calcium. Inflammatory conditions like rheumatoid arthritis are a predictive risk factor. Disuse atrophy if somebody's in a wheelchair, and then multiple myeloma is a very rare cause of this. Our demographic for this is going to be Caucasian and Asian women, usually over the age of 50 because they're postmenopausal. Here's your exam question. The DEXA scan is a diagnostic criteria for this, and it's going to be a T-score of -2.5 or less. That's standard deviations. Osteopenia is indicated by -1 to -2.4. The FRAC score is something that can be calculated for patients that don't have a history of fragility fracture, and their FRAC score is in the their T-score is in the osteopenic range. If somebody's over a 20% overall risk for fracture or over a 3% risk for hip fracture, that's considered osteoporosis. In the workup of this patient, you want to look at a CMP looking for calcium levels, liver function, renal function, alkaline phosphatase, look at their magnesium levels, their vitamin D, and their parathyroid hormone. Treatment for this, we want to supplement vitamin D and calcium to the appropriate levels. If they have a compression fracture, bracing or kyphoplasty can be considered. Treatment for this, estrogen replacement, things like hormone replacement therapy, selective estrogen receptor modulators like Avista, anti-resorptive therapy like bisphosphonates that all end in dronate, so alendronate, resindronate, osteoclast inhibitors like Prolia or denosumab, If the patient has severe osteoporosis, anabolic medications are indicated. This would be things like Forteo, Tymlos, and Avinity. Next, we have osteoarthritis. We get osteoarthritis from hard work and birthdays. Remember, this is different from rheumatoid arthritis, which was autoimmune complexes in the joint. So in osteoarthritis, this is this chronically developing joint pain, months to years. Typically is worse in the morning and worse with weight bearing and overuse. So if they do a lot of things like if they crochet or they knit or they're really hard on their hands. It usually gets better once you get moving, and it can be aggravated by trauma. So they can have pre-existing arthritis, have no symptoms, have some trauma to the area, and now they've kind of aggravated those osteoarthritis symptoms. Tenderness over the joint line. You may have a joint effusion or swelling. The joint may become enlarged. This is common in the hands and in the knee. Crepitation or crunchiness with pain on a grind test as you're grinding those bones together. Painful and decreased range of motion. Heberdine's nodes and Bouchard's nodes. Bouchard's nodes affect the PIP joint and Heberdine's nodes affects the DIP joint. Remember, Bouchard's comes in the alphabet before Heberdine's does. This is hard work and birthdays. So age and use causes joint erosion and destruction that eventually leads to friction and osteophytes. Then the osteophytes start rubbing together, and that just kind of worsens that process. This commonly affects our weight-bearing joints, the knee, the hip, the spine, and the hands. Things that contribute to worsening of this: trauma, genetic, age, and obesity. Remember that with the knee joint, the knee carries 3 to 6 times the body weight. So the more obese the patient is, the worse their knee osteoarthritis typically is. With osteoarthritis, this is hard work and birthday. So we don't usually see this until at least the 5th decade of life. But it really depends on what they did for a living. If they have a very physically demanding occupation, so constructions, people work in construction, runners, cyclists are very hard on their knees. On x-rays, if we look at this bottom picture here, subchondral cysts, they look like little black dots around the cyst. Narrowing of the joint space and osteophytes or bony growths around that joint. Treatment for this: weight loss, activity modification. In orthopedics, we have a rule that says if it hurts, don't do it. Excuse me. Unloading joint braces. Anti-inflammatories can be either systemic or topical, things like Voltaren gel. Corticosteroid injections can be given on a limited basis. Visco supplementation, things like hyaluronic acid. This is given in the knee only. And then finally, total joint arthroplasty, where you actually replace the joint components. Next, we have septic arthritis and osteomyelitis. This is infectious process. Septic arthritis is going to be an infection into the joint. So this is a joint infection, most commonly caused by hematogenous spread. Acute joint pain for hours to days. That pain is much worse with movement. They may have a history of systemic things like fever. They may have a new sexual partner. We know that gonorrhea is a common cause of septic arthritis. So on exam, that talk picture there, the joint is going to be red. It's going to be hot. It's going to be swollen. It's going to be tender. Pain with passive range of motion is a really important physical exam finding for septic arthritis. So if it hurts when you're moving it, that's a common finding with septic arthritis. Excuse me. Under the age of 40, we think about gonorrhea. Over the age of 40, in people who has prosthetic joints, we think about Staph aureus and streptococcal species. People who have Lyme disease, remember Borrelia burgdorferi, that's the causative agent of Lyme disease. Pseudomonas, we think about with IV drug users, because remember, this is a hematogenous spread. For our lab findings on this one, SED rate, CRP will be elevated. CBC will show a leukocytosis. When we pull the fluid out of the joint and we send it for analysis, we'll look at Gram stain, culture and sensitivity. We'll see an elevated white blood cell count. On X-ray, you may see periarticular osteoporosis. The bones kind of look ghosty gray or ghosty white on the X-ray. Treatment for this is going to be an emergent. We need to call our orthopedic friends and get them involved. Emergent incision and drainage to wash out that area. The solution to pollution is dilution. You have to wash that area out. The antibiotics should be given per the culture and sensitivity, and common ones are going to be our fluoroquinolones, penicillin, and cephalosporins. Osteomyelitis is a bone infection. So septic arthritis is a joint infection. Osteomyelitis is a bone infection. Remember that septic arthritis is usually going to be a hematogenous spread. whereas osteomyelitis is usually caused by some kind of direct puncture in the area. So systemic symptoms like fever and malaise. In the area, inflammation, edema, erythema, pain, very similar to our septic arthritis. So bone infection most commonly caused by a puncture, a foreign body, or those who have prosthetic joints. This may spread from the septic arthritis and infect the surrounding bony area. So Staph aureus is going to be our most common. Pseudomonas, again, in our IV drug users and our immunocompromised patients. We can also have a contiguous focus, a spread from diabetic foot ulcers or people who have vascular compromise in their extremities. Elevated SED rate, CRP, CBC shows leukocytosis. The blood culture has about a 50% sensitivity, but a bone biopsy is our definitive test for osteomyelitis. On X-ray, we don't usually see any changes for at least 1 week, but after a while, we can see cortical thickening, sclerosis, and osteolysis in that area. On nuclear bone scan, we'll see increased uptake in the area of the infection, and then an MRI can also be definitive for this as well. If it's a fracture, we can place antibiotic beads in that area. Oral antibiotics, including clindamycin, rifampin, Bactrim, and fluoroquinolones. Surgical debridement of the area, and then if there's hardware in the area that's infected, we need to remove that as well. Bone tumors. In bone tumors, we talked about sarcomas, which is soft tissue tumors. In bone tumors, these can either be lytic tumors where they destroy the bone, blastic tumors where they grow bone, or a mixed origin for this. In the history, look for a new onset of bone pain, a new limp, a fracture with minimal trauma, if it's a pathologic fracture in that area that's compromised. If it's metastatic, night sweats, weight loss, fatigue, we know those are all B symptoms of cancer. If it's a very superficial bony tumor, they may have a firm bony mass in that area, but if it's a deep tumor, you may not feel it. Benign types of bone tumors include osteoma, osteochondroma, osteoblastoma, enchondroma, giant cell tumor of the bone, and an aneurysmal bone cyst. Malignants are osteosarcoma, chondrosarcoma, Ewing sarcoma, and fibrosarcoma. Here's a really good exam question coming up here. Metastasis occurs to the bone most commonly from BLT and a kosher pickle. The most common cancer to metastasize to the bone is going to be breast. Then we go lung, thyroid, kidney, prostate. Some specific findings that may be described to you in the question on an enchondroma has a popcorn pattern to it. An osteochondroma, remember that's the most common benign lesion, it will look like a cauliflower. It has a stalk and a cap. Multiple myeloma, we've discussed this in several units already. This is going to be a punched out lesion in the bone. This is associated with the Crab syndrome, hypercalcemia, renal decline, anemia, and bone lesions. Osteosarcoma is the most common malignant lesion. This is going to be in pediatrics typically, and it has a sunburst type of pattern. Ewing sarcoma is going to have an onion peel or a sunburst pattern. And then this one is associated with an 1122 chromosomal translocation. So all of this stuff that we're talking about here is really good fodder for board questions. We see a presence of teen and young adults for osteosarcoma and Ewing's, and then over age 40 is typically going to be their multiple myeloma and metastatic forms of cancer. So on diagnostics, we want to identify that primary cancer. Multiple myeloma will be a positive protein electrophoresis. We may order an X-ray, a CT guided biopsy, which is going to be definitive because we're getting cellular components of that. And then we order a PET scan for staging. The treatment for this really depends on what type of cancer it is. If it looks like a fracture is imminent in that area, you can perform a prophylactic fixation to prevent that fracture, excision plus or minus amputation, depending on how malignant it is, radiation, chemotherapy, and then CT guided radiofrequency ablation. Really very much depends on the type of tumor. With our bone tumors, here's an example here. So there's that enchondroma. There's the osteosarcoma in the second picture there, the multiple myeloma, and then an example of what Ewing sarcoma would look like. So all good testable material there. Next, let's just talk about some general orthopedic injuries. How do we approach a general orthopedic trauma? For the history, we want to determine, was this a high or a low injury? What was the time frame of injury? How long ago? Is there any potential sources of contamination? Do they have numbness? Do they have difficulty moving the area? So all good history questions there. When we're performing our physical exam, we want to inspect the joints above and below the area of trauma, and we can compare them to the contralateral side. We want to evaluate for edema, any kind of discoloration, deformity, range of motion. Think about the anatomy that lives in that area. And if you need to Google it to try to figure out what could potentially be affected there. Test their sensation, their capillary refill, their pulses. Do they have tenderness? Do they have crepitus or crunchiness in that area? Things that are red flags and we emergently need to call for an orthopedic consult: erythema, purulent drainage, painful passive range of motion. Remember, we're thinking about the septic arthritis for that one. Etiologies for injuries: fracture. Fracture is a disruption in the cortex. If it's an open fracture, that means that the skin is open. Closed is that the skin is intact. Stress fractures usually occur from repetitive trauma. So things like runners, you may see that in. Dislocation, there's no articular contact. Subluxation is when there's still some articular contact. A strain is a tear of the tendon. Remember, T for T. A sprain is a tear in the ligament. First thing we want to do is order x-rays. Is the fracture angulated? Is it displaced? CT scan can help if the x-ray is inconclusive, and that's going to be best for evaluating fractures. MRI, if we're thinking if it's a soft tissue injury, so tendon, ligament, or nerve damage. And if it's infected, you want to culture that drainage. Treatment for this: let's reduce our deformities. Anything that's a dislocation, subluxation, or long bone fractures should be reduced or put back into place with longitudinal traction. Ensure that that patient's tetanus is up to date. Remember, that's every 5 years. You want to irrigate if there's gross debris in the area or purulent drainage. Emergent orthopedics consult. This is a good exam question here. If it's irreducible, if it's intra-articular infection, if it's compartment syndrome, if there's neurovascular compromise, you immediately want to get somebody involved. You want to get them to the orthopedics within a few days if the fracture requires surgery, if they have a laceration to a tendon, ligament, or nerve. If the patient has a trauma to their extremities, you want to remove any types of rings or jewelry in the area because edema can constrict that area and cause ischemia. If it's right after the injury or they're very swollen, you want to splint because a splint only has one side with a mobilization and it allows for edema and can prevent that compartment syndrome. If they have mild edema or if it's been a few days after the injury, you can cast them. So that's a circumferential immobilization and it does not allow for edema. So we want to make sure their edema is under control before we do that. If it's a sprain or a strain, their x-rays are negative. Rest, ice, heat, compression, elevation, that's our RICE, rest, ice, compression, and elevation, and then anti-inflammatories. Let's look at our fracture lines. And remember for the boards that fracture types are commonly tested, and they may just give you an x-ray and say, what's fractured or what type of fracture is this? The most common fractures when we're describing them. So transverse goes directly across. Oblique is at an angle. Comminuted is kind of multiple pieces exploded. Spiral is usually the result of a twisting injury, and that can be indicative of something like child abuse. An avulsion fracture is where a little piece of the bone is pulled off. Impacted, the ice cream is shoved into the cone. Green stick, if you were to bend a green stick or a new stick on a tree, you'd get kind of a break in one side and a bend in the other. And then a torus or a buckle fracture is very common in kids because their bones are relatively soft still. Salter-Harris fractures are specific type of fractures that occur only in the growth plate. So this is only going to be in our pediatric patients. So you will never see a Salter-Harris injury in an adult. Depending on how bad it is, it can cause physeal arrest or stopping of growth of the growth plate in about 7% of cases. The older the kid is, the less chance they will have a deformity in that growth plate because they're mostly done growing at that point. Lots of questions on the boards on the Salter-Harris fractures. So SALTR, that kind of reminds us on type 1, type 2, type 3, type 4, type 5. So type 1 is going to be straight through the physis or straight through the growth plate. Type 2 is going to be the most common type of Salter-Harris fracture, and that's above through the physis and the metaphysis. Type 3, lower, goes through the physis and the epiphysis. Type 4 is an angle. It goes through the metaphysis, the physis, and the epiphysis. And then type 5 is rammed, where you actually have the growth plate get smashed up into the bone. This is just what things look like for casting. So a short arm cast versus a thumb spica cast versus an ulnar gutter cast. We also have a radial gutter cast that's less common. Long arm casts include the wrist and the elbow, and then buddy tape is for finger injuries. Short leg casts, long leg casts include the knee. A cam boot or a controlled ankle motion boot is good for ankle and foot injuries. And then a hard-soled shoe would be things like metatarsal injuries. So let's look at some x-rays here. Remember, for the boards or your exam, they may just give you the picture and ask a question. So the first one we'll look at is a clavicle fracture. This is the most common fracture that occurs during birth, and it is very common also in contact sports. Humeral shaft fracture, a good exam question about this one is it is most likely to cause radial nerve damage, which remember leads to wrist drop because it goes through that spiral groove. Next, a supracondylar humeral fracture. This is a very common fracture in kids. And the two sign findings that we see is the anterior sale sign there. You'll see kind of a darkish area and the posterior fat pad. Let's go back to that one. And the posterior fat pad, that's in blue. A nightstick fracture is specifically an ulnar shaft fracture. That's a raised forearm to a direct blow. That's the mechanism for that one. Colles fractures and Smith fractures. The Colles fracture is the most common type of wrist fracture. This is a fracture of the distal radius where it's dorsally displaced. This occurs from a fall on an extended wrist, and this deformity is commonly called a bayonet or a dinner fork deformity because that's kind of what it looks like. So you can see that dinner fork there. Again, the Colles fracture is the most common wrist fracture. A Smith's fracture is kind of the opposite of a Colles. This is a distal radius that's volarly displaced, and this is usually a fall on a flexed wrist. A Galeazzi and a Monteggia fracture. These are also common on the boards. In a Galeazzi fracture, this is going to be a distal radius fracture and a dislocation at the wrist of the radioulnar joint. So Galeazzi is going to be at the wrist. A Monteggia fracture is going to be a proximal ulnar fracture and a dislocated elbow, so a dislocated radial head at the elbow. So remember, Galeazzi's wrist, Monteggia is going to be at the elbow. Remember, Monteggia is ulnar, Galeazzi is radius. Scaphoid fracture. A scaphoid fracture occurs due to a fall on an outstretched hand, and they'll have tenderness over the anatomical snuff box that you can see in that bottom picture there. The anatomical snuff box lies between the EPL and the EPB tendons. The reason that this fracture is so important is that if you miss this fracture, it can cause avascular necrosis because there's a very poor and fragile blood supply to that scaphoid. Also about this one is that you may not see this fracture on x-ray for up to 2 weeks. So if you have this on a board question, they ask you, what's the most appropriate treatment for this? It's immobilization, either with casting or splinting for up to 2 weeks, and then you want to repeat the x-ray. So tenderness over the snuff box should be an assumed scaphoid fracture. A gamekeeper's or a skier's thumb. This is going to be a torn ligament at the thumb MCP, the ulnar collateral ligament, where you can actually bring their thumb all the way down. So radial deviation of the thumb because there's nothing keeping it attached. A boxer's fracture or a brawler's fracture or a barroom fracture, lots of names for this one. This is a very commonly tested one on your exam because it's common in real life. This is a fracture at the small finger metacarpal neck that's caused by axially loading of that bone. An open book or a pelvic fracture. This is going to be a fracture because the pelvis is a ring. When you have a fracture in one area, you get fractures all over. So pubic symphysis plus a pubic rami plus a fracture of the sacroiliac joints. The most commonly injured vessel on this one is going to be a superior gluteal artery hemorrhage. Tibial plateau fracture. So we're moving down into the leg now. This is usually a very high energy type of trauma. So a motor vehicle collision or a fall from a very high height. Proximal fibular fracture. Their weight bearing will remain intact because remember the fibula is a non-weight bearing bone. This is when this injury happens, it can damage the peroneal nerve, and this can lead to foot drop on this one. Knee dislocation. The common injury that occurs with a knee dislocation is that that bone comes back into the popliteal space, and that can damage the popliteal artery and the peroneal nerve. Liz Frank injury. This is usually some kind of violent twist as the foot is stuck in plantar flexion. This is a dislocated tarso-metatarsal joint, and you can see that blue arrow at that location there. Jones fracture. This is a fracture at the proximal fifth tarsal, the metaphyseal diaphyseal junction. This is usually due to some kind of foot inversion injury. A calcaneal fracture, also called a lover's fracture, because people used to jump out the window when the parents would come into the room. So a lover's fracture, fall from a height directly onto the heel. The Bowler angle is something that we can calculate. And if the Bowler angle is flattened, that can indicate that they have a calcaneal fracture. Femoral neck fractures and compression fractures. These are commonly called fragility fractures because they are common in patients with osteoporosis. In the femoral neck fracture, the most likely vessel to be injured is the medial femoral circumflex artery, and this can cause avascular necrosis of the femoral head. In compression fractures, they develop kind of this wedge-shaped fracture. And once you get one compression fracture, it changes the alignment of the spine, so you're more likely to continue to get these. These are most common at the thoracolumbar junction, and it forms, again, this wedge shape. Spondylolysis, this is a defect in the pars interarticularis, and this is most common at L5S1. This is what we call the Scotty dog with a collar. And if you look at this on X-ray, it looks like, so you see that the picture over to the left here, looks like that Scotty dog is wearing a collar where you see that fracture at. So it's kind of the outline of a Scotty dog. Spondylolisthesis is where the spine has kind of subluxed on each other. So this is a displacement of the vertebra, and it's usually anterior displacement of this. The most common place, again, is L5S1 for both of these. That was a big part of the first unit there. Remember, musculoskeletal is a huge part of your PANCE test. So if you're interested in learning more, you can buy the rest of this review. You'll also get a full review PDF with this one. If you want to do even more, we have practice tests that are available along with a clinical pearls matching exercise. The links for this are available in the information for the video, and I'll just show you an example of these real quick. The clinical pearls matching exercise, you can do this an unlimited amount of times. And this helps you with repetition, matching the most commonly tested things about the disorder to the disorder itself. We have a didactic level practice test, which is a moderate level difficulty that's geared to be about the level difficulty in your didactic year. You'll get an answer explanation for any questions that you may have missed so that you can go back and study that information and not get it incorrect on your actual test. And then we have a boards level test here as well. The boards level test is geared to be a little bit more difficult. So there'll be 5 answer choices. They're a much more challenging difficulty than your didactic year. And again, you'll get an email for any of those missed answers so that you can study that information. Thanks again for watching. I hope that you have a great rest of your day. I hope that this helped you here. Just as a legal reminder, this is not designed to be medical advice. It is designed for educational purposes only. All of our sources are cross-referenced with peer-reviewed medical journals, textbook, and evidence-based medicine websites. So thank you for watching, and I hope you have a great rest of your day.